Just going into the background of retinal imaging, we all know that retinal photography has definitely evolved rapidly since its inception in 1959, where we used to use flash tube, electronic flash tube photography and black and white film-based angiography, fluorescein angiography. In the 1980s was the era of digital retinal imaging, and that created a real revolution in the retinal imaging history. In 1990s, we saw the introduction of OCT technology, and in the past decade, there has been a new addition to the imaging front in the use of fundus autofluorescence technology. Fundus autofluorescence, relatively new imaging modality, focuses on the fluorescent properties of the pigments in the retina and generates images that help us view various disease processes from a very different perspective. We all know that lipofuscin is a byproduct of the phagocytized photoreceptor outer segments that accumulates in the retinal pigment epithelium with age, as well as with certain diseases. FAF allows the topographic mapping of the lipofuscin distribution in the RPE as well as of the other fluorophores that may occur in disease in the outer retina and the subneurosensory space. So to understand autofluorescence, we do need to understand the distribution pattern of lipofuscin in the normal retina. So what are the current applications for autofluorescence? The method, of course, is non-invasive. It gives you a quantitative figure, and it is an objective diagnosis. It allows visualization of characteristic changes. It can confirm some of your suspected diagnosis. It helps the detection of phenotypes and also helps in the monitoring of disease. How do you evaluate autofluorescence? So you can have either fundus autofluorescence or hyper. Hypo is where there is a reduction in the RPE lipofuscin density. There's increased RPE melanin content, for example, in RPE hypertrophy, or absorption from this extracellular material cells fluid anterior to the RPE. So all this will give you a hypoautofluorescence, which is dark or black. And hyper fundus autofluorescence is due to the excessive RPE lipofuscin accumulation and occurrence of the fluorophores anterior or posterior to the RPE and cell monolayer, lack of absorbing material, and, for example, optic nerve head drusen. So basically, if you have hypofundus autofluorescence, your RPE cell is already dead. And if you have hyper fundus autofluorescence, the RPE cells are dying. So that's what it tells you. Geographic atrophy has been one of the major disease areas where fundus autofluorescence has really helped. And I think most of you might have come across Frank Holz, who is considered to be the guru of fundus autofluorescence, and how he has actually come up with what are the different methods in which geographic atrophy can be identified and classified. So in this slide, you can actually see the unifocal geographic atrophy versus multifocal lesions of geographic atrophy as seen on FAF. And again, it was Frank Holz who actually decided to classify geographic atrophy, class 1, which is small areas of foveal atrophy without increased fundus autofluorescence, class 2, which is small to moderate areas of atrophy with increased FAF, class 3 is moderate areas of atrophy with increased FAF, predominantly multifocal pattern. Class 4 is large areas of atrophy, predominantly multifocal with increased FAF elsewhere as well. And class 5 would be large areas of atrophy with increased juxta-atrophy. Now looking at that in a pictorial fashion, this is what you see in the different classes. So like I said, it actually gives you a really good idea about the different patterns of geographic atrophy and how that will actually go forward in the progression of the disease. Now, in geographic atrophy, there are abnormally high levels of fundus autofluorescence in areas which are immediately surrounding the the hypofluorescent areas. So for example, if you see the black area, you will see an area just surrounding it which has got hyper-autofluorescence. And this is called your junctional zone. And what they say is that this is the area between your normal retina and the atrophic retina. The RPE here is working over time, and this is gives you an idea of the imminent atrophy that is going to take place in that area. And these distinct abnormalities do not show up in any of the other imaging modalities you can think of. It only shows up on FAF. So here, this is what I'm trying to show you. So this is a patient who has been followed up. Sorry. And if you look at this, there's autofluorescence just nasally as compared to the temporal and the superior and inferior margins. And if you look at it, by the third year, you can see that that area in nasally has started atrophying, in addition to the fact that the central area has already enlarged. So, this tells you how the geographic atrophy is going to progress. And here again, like I was telling you, it also allows you to identify different phenotypes. So geographic atrophy has got these various phenotypes where looking at the areas of whether there's presence or absence of hyperfluorescence gives you an idea about what type of phenotype you're looking at. And this is based basically on the junctional zone that I was talking about. Now, this is again a patient who's been followed up who had multifocal geographic atrophy, and you can see that the lesions are increasing as years go by. And this sort of thing is really important now that we have treatment for geographic atrophy. Previously, geographic atrophy was not of interest to us because we did not have any treatments. Now we have quite a few trials going on. We have the lampalizumab trial, the chroma and spectri studies, which actually depend on fundus autofluorescence to decide whether the patients are eligible. Because with the geographic atrophy trials, what you're trying to do is look at the progression and stop the progression of the disease. Similarly, you have trials using brimonidine implants, again doing the same thing. And both these trials are looking at multifocal lesions as opposed to unifocal geographic atrophy. Like I said, the progression of geographic atrophy can be measured, and the best way of doing that is using region finder. So if you have your confocal scanning laser imaging technique like with the Spectralis or the Heidelberg Spectralis machine, you can actually use region finder to measure the area of geographic atrophy, and that gives you a really good idea about the progression of the disease. We conducted a small study in our unit looking at whether the progression of geographic atrophy and its relation to visual acuity. And what we found was that although there was an increase in geographic atrophy, this was a 3-year study, over the 3-year period, we did not find that this correlated very well with the visual acuity itself, i.e. the visual acuity didn't necessarily go down as the geographic atrophy increased. And this could be because of the foveal area where the atrophy is still not present. Now, what about neovascular AMD? I mean, is there any use of fundus autofluorescence in neovascular AMD? Again, it can be used in trying to give a patient a prognostic indicator. It was Alan Bird who came up with this, who had done a study on a series of patients who had neovascular AMD, looking at the autofluorescence patterns and deciding whether there would be the prognostic indicator as visual acuity. His study was for 5 months and found that at the end of 5 months, it actually did give you a prediction. However, when we did this study of 60 eyes, treatment-naive patients treated with for exudative AMD, we found that at the end of 12 months, unfortunately, there was no statistical significance on the foveal autofluorescence pattern and visual acuity. However, foveal autofluorescence images that we used in the study, were retrospectively analyzed, and they correlated very well statistically between the two observers. So, i.e. saying that you could actually make sure the imaging technique itself can be used. So what we did was, like I said, use the and analyzed for normal or changed autofluorescence, i.e. increased or decreased, or increased and decreased pattern around the 50 micron and 500 and 1000 microns. And like I said, it did not prove to be a predictive tool at the end of 1 year. However, the kappa statistics did show that there was no significant inter-observer variability when you were rating the autofluorescent images itself. Again, retinal dystrophies and degenerations, retinitis pigmentosa, very good method of keeping track of the progression of the disease with autofluorescence is where you can see both hyper and hypoautofluorescence suggesting that the retina is burning out. Similarly, another great disease that you can look at with fundus autofluorescence is Stargardt's disease. It's particularly useful in diagnosing because you can actually see the pisiform lesions very clearly using fundus autofluorescence. Best disease, again, is characterized by macular and submacular accumulation of lipofuscin, as we know already. And this is sharp characteristic hyperfluorescent region in the macula, and the FAF shows the widespread abnormalities, because what you see on the color image does not give you a correct indication of how far the disease has progressed, whereas using autofluorescence, you could get a good idea. Again, with central serous retinopathy, you can actually see the extent of CSC best with autofluorescence, and not just the area of subretinal fluid, but all the areas where the retinal epithelium has been affected in CSC. Diabetic macular edema, again, FAF correlates better with OCT patterns and central visual field microperimetry rather than visual acuity in patients with diabetic macular edema. So dynamic fundus autofluorescence monitoring helps you to evaluate the disease, progression of DME, as well as the visual function. And even you can even quantify fundus. There was a study that actually quantified fundus autofluorescence and found that to be very good as a diagnostic indicator. So here you can see in diabetic macular edema, the fundus autofluorescence patterns where you have normal FAF, and then you have the single spot of increased autofluorescence, and then multifocal pattern of increased autofluorescence. Again, like I said, you can correlate that with your OCT, diabetic macular edema findings, showing that large foveal cysts, etc., and showing the same pattern on fundus autofluorescence. To summarize, therefore, the role of fundus autofluorescence imaging is still evolving, but it provides you with unique information to complement that obtained from other imaging modalities. With practice, it is possible to seamlessly integrate fundus autofluorescence imaging into your other methods to gain a more complete understanding of the patient's condition. As Rick Spade points out, when you're learning tennis, you learn all different shots, etc. And then when you become a seasoned player, you use all those shots as you play. So similarly, that's what this stage autofluorescence is at. Thank you.